very much. Thanks for inviting me to speak today. I have a lot to go over, so I'm going to just breeze through this. So I'm just going to start off with a case, a patient that we commonly see in our clinics, 51-year-old gentleman who's a truck driver, which similar to what we do, he sits a lot. Has a history of hypertension, rheumatoid arthritis, and sleep apnea. He came to our office complaining of chest pain. He'd been having chest pain for the last few months, sometimes exacerbated by activity when he was getting on and off of his truck. His pain was sharp, substernal, would last for about 30 seconds. He reports that he sometimes had to slow down at work, but not always. He reported some minimal shortness of breath associated with this and would sometimes get relief when he belched. Kind of quickly with his past medical history, hypertension, sleep apnea, and rheumatoid arthritis. He was a truck driver, and he had a former smoking history, but currently doesn't smoke. A few medications for blood pressure and methotrexate for his RA. Blood pressure was slightly elevated in clinic, and his BMI was 33, heart rate was 55. Otherwise, his exam was normal. Had a fairly normal appearing EKG in the office. Lipids, his LDL cholesterol was elevated, 176, and A1C was 6.0. So if you saw this patient in your clinic, what would be your next steps? You know, invasive coronary angiography, reassurance, treadmill stress testing, coronary CT, or pharmacologic nuclear stress testing. Just answer in your head. So today we're going to talk a little bit about the outpatient evaluation of chest pain. We'll differentiate between different causes of chest pain, understanding the different modalities of testing, including stress testing and functional testing versus anatomic imaging with coronary CT plus or minus FFR CT. And at the end, we'll talk briefly about the future applications and directions of imaging for the assessment of coronary artery disease as well. So a lot of this talk is based off the 2021 guidelines for chest pain that were published in JACC. Very extensive and great document to review that goes a little more in depth to what I'm talking about today. So whenever we see a patient in the office and they have chest pain, one of the initial steps is just stratifying their risk. And stratifying risk can include, there's many different models out there, the classic being the Diamond Forster model. Pretty much all of the risk models take into account the type of chest pain, whether a patient has non-anginal chest pain, atypical chest pain, or typical chest pain, but also accounts for age, as Dr. Lash alluded to as being a big driver for this, as well as other cardiovascular risk factors, including family history, smoking, inflammatory disease, dyslipidemia, hypertension, diabetes, et cetera. The quality of pain is also important, and this image on the right was from the guidelines where they describe the type of pain and the probability of ischemia, with more central pressure squeezing, heaviness in the chest being more indicative of ischemia, and sharp, fleeting, or pleuritic type chest pain being less likely. So, you know, as far as assessing for the cardiac etiology of chest pain, I think there's two large categories to think about how you want to test somebody. Functional testing, which is our traditional stress testing pathway, versus anatomic imaging. For several decades, we only really had functional testing as the CT technology wasn't really available, but now we have a lot more availability for that, and we'll go over kind of which patients we should use which for. When thinking about functional testing, it's important to think about the ischemic cascade. This is a model that shows, depending on the duration and magnitude of ischemia, what changes within the heart. So initially you get metabolic changes, then you get abnormal perfusion within the heart, which is the abnormal blood flow. This leads to cellular changes on a cellular level, which eventually leads to diastolic dysfunction initially and then systolic dysfunction. After that, you'll see ST segment changes and then symptoms and then myocardial necrosis. And as you move up this pathway, the different types of tests assess for this different ways. So treadmill stress testing will look for ST segment changes, stress echo will look for systolic dysfunction, and myocardial perfusion imaging will look for perfusion changes. And as you move down the ischemic cascade, the lower you get, you're going to have a more sensitive test. The higher you're going to get, you're going to have a little less sensitivity in your testing. So exercise treadmill stress testing is kind of the initial test that we talk about for lower risk patients. It's a test that we like to use because it's low cost, highly available. However, and it doesn't expose patients to radiation, and it gives good prognostic data and data regarding functional capacity. However, the sensitivity and specificity of this test are low, approximately 70% for both. It's particularly lower in patients in women in particular, having a sensitivity of about 50% in women, and also having a lower sensitivity in those who have known coronary disease or have baseline EKG changes, namely ST segment depressions at baseline. And then you must be able to exercise to get this done. So stress echocardiogram, moving down the ischemic cascade a little bit more, is also a test we use that adds imaging onto our treadmill stress testing. Again, this does not expose patients to radiation, but it does have improved sensitivity and specificity ranging around 80%. It is technically a difficult study. So for patients who have poor echocardiographic windows, it's something we wouldn't recommend. And that's hard to predict when you're seeing a patient at the office, but patients who have COPD, who have breast implants, who are obese, it's very difficult to get good windows, so just keep that in mind. If patients have pace rhythm, that's something we would avoid as well. So kind of the workhorse for years has been nuclear SPECT imaging. And nuclear SPECT imaging is great because we can do it for most of our patients. Patients who have known coronary disease, who have had prior bypass or prior stents or prior infarcts, we can do this effectively. It has improved sensitivity and specificity to compare to treadmill stress testing, being a little more sensitive than specific. There is kind of one group that we have to be really careful of for patients who have multi-vessel disease. When we do SPECT imaging, we're looking at differential perfusion defects. And so when you have perfusion defects in all of your coronary vessels, sometimes that can lead to false negative test. It does expose patients to radiation, and you can't exercise patients who have a left bundle branch blocker or pacemakers, but you can do the test. PET imaging is similar to SPECT. It does have improved sensitivity and specificity over SPECT, primarily because we're able to quantify blood flow using something, assessing myocardial blood flow reserve. We prefer this in patients who have large BMI, so BMI over 40, or sometimes when patients have false positive SPECT tests in the past. We are able to attenuate correct, so we are able to correct for some of the problems that we have in our SPECT imaging, patients who have difficulty with SPECT imaging. Availability for this is somewhat limited. It does expose patients to radiation. It does have higher costs, so sometimes it's a little difficult to get this approved through insurance. And then stress MRI, we don't have this available in NORNS, but it's also an option. I'm not going to spend much time on that. So as I alluded to earlier, I think there are some differences in the specificity and sensitivity of these tests with men and women. So as you see here, treadmill stress EKG has a sensitivity approaching around 50% in women compared to about 70 to 80% in men. So keep that in mind when you order one of these tests. As you move down the ischemic cascade, you can see that the sensitivity goes up. And we'll talk a little bit about the coronary CT in a minute. So in the guidelines, they quantify patients, which tests we should do based on patients' risk. So low-risk patients, it's actually a level 1 recommendation to do no testing in our low-risk patients because the incidence of disease is so low. However, if you do think a test is needed based on your interaction with the patient, they do recommend exercise stress EKG or coronary calcium score, which is not a strategy I routinely use. For more intermediate to high-risk patients, it's a class 1A recommendation for coronary CT compared to a 1B recommendation for the functional testing that we discussed. That changes because of a couple of trials that were published about 10 years ago, the PROMISE trial and the Scott-Hart trial, two studies that really changed the paradigm in how we assess for patients for ischemic heart disease. The PROMISE trial was an American trial published in 2015 where they randomized patients to getting standard care versus coronary CT. And found no major differences in outcomes, but they did show that that patients who got coronary CT actually got cathed more, but the patients who got cathed tended to get more interventions, whereas for patients who had abnormal functional tended to have more normal caths. So enriching the population that went to the cath lab, getting more appropriate interventions and more appropriate caths for patients who had coronary CT. The Scott Hart similarly also looked at standard of care versus standard of care plus coronary CT. The standard of care group primarily got exercise tremor stress. The big difference in this trial is when they followed patients long term, they found that the risk of death from MI was significantly lower in the patients who had coronary CT. And the thought was that more patients had more anti-anginals, aspirin, and lipid-lowering therapy more aggressively in the treatment group, or in the CT group. So what are the advantages of coronary CT versus stress testing? Coronary CT is an anatomic assessment, so we can look for not only symptomatic disease, but also pre-symptomatic disease. So patients who have mild plaque that's not obstructive, but that's present. It can also anatomically identify patients with multivessel coronary disease, which can be an issue with patients who are getting stress testing based on balance ischemia, as I mentioned earlier. The negative predictive value for coronary CT has a lot of advantages. So patients who have a normal coronary CT, their warranty period essentially is much, much better. So if you have a completely normal coronary CT, your risk of having a coronary event within the next 5 years is extremely low. In the guidelines, they say no further testing is needed for at least 2 years after a normal CT versus for stress testing for 1 year if patients are having persistent symptoms. The CT has higher sensitivity, as I showed earlier, and we can qualify and quantify the plaque, and we'll talk a little bit more about that later. For traditional stress testing, however, coronary CT can't be used for all patients. Some of the limitations include patients who have known coronary disease. So patients who have stents, we're not able to adequately look through them with our existing technology here. Patients who have bypass grafts we can assess the patency of the bypass grafts, but looking at the native coronary anatomy can be very difficult. To do coronary CT, we do need to get heart rate control, and so one of the advantages of stress testing is you don't need to control people's heart rates. It's readily available. You can get a functional assessment of the patients, and can be performed in patients with previous coronary disease. Stress testing also does not require IV contrast, so patients who have renal dysfunction or allergy to contrast, that's a good option. So I think we order coronary CTs, but we don't always know exactly what happens when people go in. And so I think understanding the actual preparation for the procedure is very important. So for coronary CTs, we prefer for patients to be fasting about 4 hours. Patients need large bore IVs, generally in their AC. PICCs are generally not recommended because we can't push the contrast as fast as we'd like to. We like to get heart rate around 60 beats per minute. And so our kind of workhorse to do that is giving metoprolol for the day before and the day of the test, but sometimes we can use ivabradine if patients have low blood pressure. We give nitroglycerin at the time of test to kind of plump up the coronary vessels to give us a better assessment of so we can get a clearer look at the coronaries as well. We do give IV metoprolol if needed at the time of the test as well. I think it's important to realize, we usually push IV metoprolol at 5 milligrams, which is equivalent to about 25 milligrams of metoprolol. So you're able to load much better orally, and you get a much more steady heart rate control. So it is crucial to give oral beta blockers for patients who do have slightly elevated heart rates. So in EPIC, the CT order, CT angiogram with 3D imaging, you order the CT, but then it also has options for beta blockers and ivabradine underneath it. So it kind of helps make it a little easier to order the test, the appropriate dosing of beta blocker that we need. If patients have low blood pressure, then ivabradine is an option. That can sometimes be expensive, so something to use a little cautiously. So when should we not use coronary CT? I talked about this a little bit earlier, but I just want to reiterate the patients who we shouldn't do it on. So patients who have IV contrast allergies probably is not the preferred test unless there's a really compelling reason to use it. If people have significant renal dysfunction, Generally, a GFR less than 45 would be something to be cautious of. If patients who have frequent arrhythmias, so when patients have frequent PVCs, PACs, atrial fibrillation, or even a significant sinus arrhythmia, it's difficult to get diagnostic imaging. We're trying to take pictures of the heart, and we're trying to image hearts when the heart is not moving. So in diastole generally. If patients are having a lot of arrhythmia, it's very hard to predict when that's going to occur, and it can lead to a lot of non-diagnostic studies. So just being mindful of that before you order these tests. Patients who have previous coronary interventions, generally I do not recommend coronary CTs. Patients with bypasses or previous PCIs, because we can't really image through stents. We can't use heart flow, which I'll talk about in a minute. Patients who have BMI greater than 40, this is on the higher end for patients I order coronary. I generally don't order coronary CTs if your BMI is over 40. I would be cautious if your BMI is even greater than 35. Has a decreased diagnostic accuracy. We just get poor image quality frequently. There are certain exam protocols that need to be tolerated for a patient to get a coronary CT. So it includes breath holding, nitroglycerin, the beta blockers, as I mentioned before, or having being able to control the heart rate. And then for patients who have previously elevated coronary calcium scores, you have to be cautious. And that threshold can vary. There are some institutions that won't do coronary CTs on patients if their calcium scores are over 1,000. So that's kind of a rough cutoff to use. We scan everyone, but the diagnostic accuracy goes lower. So in the guidelines, they did have this kind of flow diagram for who are the patients we should prefer coronary CT on versus functional testing. So generally, patients who are intermediate to high risk, who are generally less than 65, although we can often push that, and patients who have a lower risk for obstructive coronary disease, coronary CT is preferred, and the stress testing is preferred for those who are a little higher risk. So the patient that we saw in the clinic got a coronary CT, and as you can see here, he had a kind of intermediate lesion in the LAD, 50 to 75% stenosis in the LAD on that images. The other coronaries looked pretty normal. So one of the issues when they did the PROMISE trial and the Scott Hart trial was we weren't sure how to adjudicate these patients who had moderate to severe stenoses, whether it was functionally relevant. So there is a technology that's developed called FFRCT, which correlates with invasive FFR, which essentially, invasive FFR measures the pressure drop around the lesion. Using the CT technology, the FFRCT is able to mimic that just based on the anatomy, looking at flow dynamics and quantitative models, and can help give us a number that's similar to that to see which patients would benefit from intervention. So in the guidelines, they said for patients who have 40 to 90% stenoses, you can use FFRCT as a tool to see if patients need any further intervention. I think with this advent of technology, it has kind of allowed us to image patients who are a little higher risk, because we're able to adjudicate these lesions more regularly rather than leading to more additional testing. How does this impact patient care? So FFRCT increases the diagnostic performance of the testing that we're doing for the patient, having an area under the curve of 0.94 compared to 0.83 when using coronary CT alone, or 0.7 for SPEC. So it leads to a much more accurate testing. It also has been shown to change decision-making in about 2/3 of patients who have intermediate stenoses. So it really impacts the patients who go to the cath lab and the sensitivity of the patients going to the cath lab. How does it impact patient care? The patients with lower FFRCTs have worse outcomes. Sorry, it's a small slide. And those who have negative FFR have outcomes similar to patients who have stenoses less than 50%. I think this is an important illustration to see how FFRCT impacts our patients. So kind of traditionally, all the patients that we have that get testing, the ones that go to invasive coronary angiography, about 30% have actually disease that requires intervention. Using FFRCT, that number goes up significantly to about 75%, with a majority of patients not needing any sort of invasive testing with the addition of FFRCT. And then you want to make sure you're not missing patients who have significant disease. There was no major adverse clinical events that happened 90 days in the follow-up period for patients who did get FFRCT. This is from a trial called the Fish and Chips trial, which was published in 2023 and was published at the ESC. And it looked at institutions that had FFRCT available versus those that didn't, and found an 8% relative reduction in all-cause mortality in 2 years. That's a pretty striking difference, and a 14% relative reduction in cardiovascular mortality. So it's a really useful additive for treating our patients and making sure we're sending appropriate patients for invasive testing. So for our patient, he got a FFRCT, and he had a significant FFRCT, so less than 0.8 is considered probably significant. He ended up getting a cardiac cath, and you can see here he had a stent put to a proximal LAD, which correlates really nicely. His lesion compares very nicely to our coronary CT picture. The patient's symptoms resolved after a single stent. He had his LDL cholesterol improved to 47 with aggressive statin therapy, and he's had no recurrent events, no recurrent symptoms 3 years after his presentation. So that's kind of where we lay now. Coronary CT now being the preferred first-line agent for patients who have no known coronary disease in certain populations of patients. But there's a lot of stuff that's developing that I think may impact some of these decisions in the future. So regarding PET stress testing, there's a new radio tracer that was approved called flurpiridaz, which will allow for patients to get exercise PET stress testing. We don't currently have this available, but hopefully will at some point. It will likely drive the cost down for PET stress eventually and allow for exercise PETs, which will hopefully lead to higher utilization of PET. Again, we don't have it available yet, just recently got FDA approved, but hopefully it will be part of the future. I think this is the thing that a lot of cardiologists are really excited about, and Dr. Lash alluded to this a little bit earlier, is a lot of AI technology driving coronary CT analysis. And one of the main things we're looking at is plaque quantification and plaque analysis. So coronary calcium just plays one role in the type of plaque that we see. The plaque that we actually worry about more is non-calcified plaque, which we can't see with our traditional calcium scoring. But with coronary CT, we are able to quantify the amount of plaque that people have. And using AI technology, we're able to get a score. This is your plaque volume. And with that, it's been shown that when you add plaque analysis to a coronary CT, that at least about 50% change in the management based on their plaque score, with a third of patients who have coronary calcium scores of 0 getting a change of management based on plaque analysis. Now, insurance isn't approving this now, but I think in the next 5 to 10 years, instead of using calcium scoring, I think we'll use a lot more coronary CT and plaque quantification as our primary tool for a risk factor modification, kind of using it like a cancer screening tool, but using it as a screening tool for coronary disease. And as you'd expect, it's tied very closely to outcomes, where the higher your plaque, the more likely you are to have an MI or a MACE event. The other advantage of coronary CT and some of the changes that are occurring with AI are imaging plaque, quantifying the type of plaque, so looking not just for calcified plaque or non-calcified plaque, but also looking for lipid-rich plaque, which is the plaque we really worry about as far as rupturing and causing MI. At this point, our therapies are the same, but I think in the next 5 to 10 years, we're going to see a lot of changes. Potentially intervention targets for these patients, but I think that's still a little early. Epicardial and pericoronary fat is also something that we can see with coronary CT that really is a predictor for myocardial infarction, and probably due to it being a marker for inflammation within the coronaries. So this has not been FDA approved yet, but I think will be part of the future if we get coronary CTs as getting a risk score for our patient more accurately. And then as our CT technology evolves, I think we will be able to image stents and CABG in the future with photon counting scanners. You can see how the difference in the blurriness of this stent compared to here, I think that will improve over time. We're not quite there yet, but hopefully will be there soon. So coronary CT so in conclusion, coronary CT is the only Class 1A recommendation for the outpatient evaluation of chest pain in patients without known coronary artery disease. Recently in the European guidelines, it was recommended as a first-line treatment, so not equivalent to stress test, but actually the first-line treatment in patients who don't have known coronary disease. But body habitus in Europe's a little bit different than the US sometimes. The anatomic assessment tends to be a little more sensitive test. There's a higher rate of subsequent revascularization when patients get anatomic assessment versus stress testing. And one of the drivers for the benefits of coronary CT is diagnosing pre-symptomatic disease, which allows us to be more aggressive at secondary prevention measures. However, stress testing still has a role, particularly in those who are older, who have a very high risk for coronary disease, patients who have known coronary disease, stents or bypasses, unstable heart rate, or renal dysfunction. And then to go back on coronary CT, using FFRCT has been shown to improve diagnostic accuracy, and the utilization of that, or having the availability to use FFRCT seems to improve outcomes long-term in patients. My references. Thank you very much.